So you really learn a lot about your body when you have this disease, and you really have to be in tune and watch everything.
It's a healthy lifestyle. I mean, that's what got us into that problem, was an unhealthy lifestyle. And the way you reverse it is to try to convert back to an un-American lifestyle, and that is exercise and diet.
Yeah, this business about portion sizes is very interesting, because studies have shown that the portion sizes served in restaurants have grown phenomenally in the last 30 years. And certainly that has contributed our idea of what constitutes a normal meal.
Right.
I would think certainly.
Well, if you remember McDonald's, originally your first hamburger was one patty, and the French fry was this little thing like this, and your Coke was a Coke like this. Now you get a triple fillet, you get the supersized fry that looks like a quart jar, and then you get your 12-gallon Coke to go with it, and that's a meal. And so you can imagine you can get your total nutritional requirements for a day in one meal.
And this is what children are growing up with. They're growing up learning this. At least
That's
adults have learned this further on in their lives, but children are growing up thinking that this is the way it's always been, and this is.
And that's why you ask why the childhood obesity and diabetes. It's directly related.
We talked about that last week, exactly why suddenly are we seeing this epidemic of childhood obesity. Karen, let's talk specifically about this area, because this area, we know, nationally, what are we seeing in terms of diabetes, and how does this area differ? Is it lower or higher than the national average?
Well, it's both are increasing nationally and in the state of Ohio. There aren't a lot of good data about specifically southeastern Ohio, but what we do know is that it pretty much falls in line, that it's a doubling in the last 10 years of diabetes.
What we have found, we have had several federal grants and a state grant to do prevalence rates in southeastern Ohio, and we have now completed 9 Appalachian counties, and we're finding that the prevalence rates in these counties is higher than the state average, and it's actually approaching some of the higher risk areas that we talk about the ethnic groups. And so what that implies to me is that it's not a genetic risk as much as it's a socioeconomic lifestyle risk. And so where you have the pockets of higher obesity and poverty, that's where you're going to see higher density foods, fear of being hungry, eating more when you've got that meal because you don't know when the next meal is going to come through. You know, we've got some experts here that are experts in the field of fear of hunger. And so I think that contributes a lot too.
Oh, no, so this is very interesting, because you were saying on the last show, Karen, that one of the risk factors, the non-modifiable risk factors, has to do with ethnicity. We see a higher rate of diabetes in African American groups, among Native American groups.
And Latinos.
And Latino groups. But now, Frank, you're saying that we're seeing it now more associated with, we think it's poverty that's associating, not necessarily probably.
Well, it's socioeconomic, I think. I mean, I've been practicing it for 25 years in this area, and when I go to the national meetings and I hear them talk about those high-risk groups, I'm saying, I see the same thing here. And so that's what prompted us to try to do prevalence data to confirm that suspicion. And what's interesting, if you take Appalachia as a whole, it's not just all of Appalachia, because you know we have some rural areas and we have some urban areas, but there are clusters or pockets of more poverty and higher rates of obesity, even within the 9 counties that we've looked at so far. So I think there is a big socioeconomic component to it. Whether there is a true genetic risk or not, I'm beginning to wonder about that.
Let's talk a little bit about the Diabetes Center that has fairly recently opened up at Ohio University, and one of the reasons is because we're seeing so much diabetes in this area. What is the center, and what is it doing specifically for this area of the country?
Well, the Diabetes Center has several missions. One is to provide care for patients in this region, and then secondly, to do research into trying to find out ways to improve diabetes care and possibly even prevent it. So we have both a clinical component with a clinical research component, and then we have a basic science component with PhD physician scientists doing research to try to find different links. We have several researchers using different animal models of diabetes, both a type 1 model and a type 2 model to see if we can find out appetite, food intake, medications, to try to develop new ways of treatment so that we can then bring that to the clinic.
Karen, let's talk about prevention. How, and Frank, you should jump in here too, because that's one of the things that the center is actually doing. What steps are being taken in the medical community now to watch for diabetes and to try to prevent diabetes among vulnerable populations?
Well, I think we talked last week a little bit about school programs for children and early prevention in terms of screening as well as physical activity programs.
And do we see schools actively involved in this? There are schools who are consciously taking part in this.
Yes.
And on what level? Is it the school nurse? Is it, are there doctors coming in and doing physicals on children? On what level are schools taking part?
Well, I think it depends on the area. There's a statewide program in West Virginia that they have programs, I think, in every county that they're screening not just the children, but the families of the children, and they're looking at prevention as a whole family issue.
And that's an interesting thing to point out too, because Chip, even when he was talking, was saying his wife went with him to the doctor to hear about diet because she was the cook in the family. So that's a very important point that I think some patients miss, that it doesn't do any good if the doctor is talking to the person who has nothing to do with diet in the household and buying the food and cooking the food. So it really is a family problem, isn't it?
Oh, and I think the success of a patient is 85% dependent on the support of their family, no matter whether it's a type 1 diabetic who needs help with just the daily maintenance or a type 2 who has to make major lifestyle changes. It's really interesting. If a man develops diabetes, the wife goes with him to all the education programs, changes the lifestyle, changes the meal menu, etc. It's very interesting that many times if the wife or the mother gets the diabetes, she doesn't want to interfere with her kid's family's life, and she tries to maintain on her own with no support whatsoever, and they fail. And so it's very, very important to get the entire family in, because what I tell the mother is, your offspring are now at risk. I mean, you're not doing them a favor by not changing their diet. You're doing them a favor to prevent them from getting what you have by changing the lifestyle of the entire family.
So in changing your own habits, you're also preventing the disease with your
That's
children.
right.
Let's listen to another person talking about their experience with diabetes.
I don't think diabetes, as whether it's a help or a curse, I don't think diabetes is really either. It has helped me realize my own mortality, because obviously had I kept on, who knows. But as far as being a curse, it's unfortunate. But had I taken care of myself in the beginning, over a period for 50 years, I've been, overweight, or was. And so when people saw me and said, "Is there something wrong with you?" I said, "Actually not. I just look like I was supposed to have looked for the last 50 years. People have lost track of what it is, of what good health is. People have lost track of how important they are to other people. And I've lost probably in the last 5 years 6 friends, some of them very close, as a result of diabetes. And I don't see any reason that has to happen. But I've tried to maintain a very positive attitude, knowing full well that it's up to me again. Everything revolves around me. If I'm not doing it, it's not going to get done. I can't rely on my wife or my children or my friends or my doctor.
Diabetes to me is a blessing, especially because mine has been pre-diabetes. I feel like it's made me take care of my knees. It's made me lose weight. I've seen my glucose numbers decrease. I think that if people, especially pre-diabetics, if they take it seriously, they can get it under control very easily, quickly. I will be diligent, and I would hope that the audience, anybody that is diagnosed with this, would be diligent in trying to make a difference in their life and do some simple lifestyle changes that we need to make